Hi, and welcome to this week's episode of the Dr. Coffee Podcast, your weekly blend of motivation, encouragement, education, and insight into all things medicine for junior doctors and medical students in South Africa. In this week's Coffee with Consultants feature, I had the great privilege of interviewing Dr. Mario Rankin, representing his specialty of orthopaedic surgery. This episode is jam-packed with goodness, so I'll try not to delay with too long an introduction. Dr. Rankin is a consultant orthopedic surgeon at the King Edward VIII Hospital in Durban and a lecturer in the Department of Orthopedics at the University of Kwazulu-Natal. He's also the intern coordinator for his hospital complex and as such has a keen interest in the development of junior doctors in his hospital and the nation. We unpack the path to specialising in orthopaedic surgery, the perks, perils and pitfalls of this discipline, and what it takes to shine during your junior years and registrar time. Then, in segment 2 of this podcast, we discuss the role of intern curators in the hospital complex, how to be the best intern you possibly can, what seniors can do to encourage and motivate interns, and how internship can be improved in the future. So, if you're a medical student or a current intern, you'll definitely want to stick around for that. Finally, this episode was recorded over Zoom and is available as a full video episode on our YouTube channel. If you're heading over that way, please like the video, leave a comment, and subscribe to the channel. It's the easiest way to support this podcast and help it to grow. And now, without any further ado, here is my interview with Dr. Mario Rankin. Welcome to the Dr. Coffee Podcast, Dr. Mario Rankin.
Thanks so much, Simon. I'm very happy to be here. Thanks for the nod. I was very happy to crack the nod for the invite. It's almost, I suppose, I made it moment, eh?
Well, you come very highly recommended by a number of people, and I'm sure that this episode is going to be highly anticipated and help lots of junior doctors and medical students. So the first question that we ask all of our guests begins with your medical training. So where did you do medical school and your junior doctor years, that being your intern and community service years?
Right. So I did my undergraduate training at the Nelson R. Mandela School of Medicine at UKZN. I qualified in 2009. Thereafter, I did my internship years at the Addington Hospital Complex. So it's Mahatma Gandhi Hospital up in Phoenix in Durban, and at Addington as well. Really had a great time there, some fantastic mentors, excellent teaching, obviously very hard work as well. But yeah, then after that, I did my community service at, I was second rounded and I went to Mpumalanga in a small town known as Ermelo, or the locals might call it Ermelua. So yes, and was actually a blessing in disguise. Look, it was not on any of my choices, but essentially a blessing in disguise, because I don't think I would have got that amount of surgical experience, hands-on experience, as I would have if I stayed in one of the major centers. So yes, in that regard, yeah, that was my junior years.
We seem to be hitting a bit of a run of consultants who trained at the Addington complex. So Dr. Nesha Naidu, one of our consultants in surgery, also did his training there, or his junior years there at least. So what was your experience like through internship? Would you say that it was a positive experience? Did it shape you well for the future? Or is there something that you would have liked to have improved upon in hindsight, in retrospect?
So no, absolutely. I think Addington, put us, I don't want to say the trenches, but it was a very good balance of hard work and mentorship, adequate teaching, and supervision, and obviously working at Addington, you have at the end of the call the beach sunrise to look forward to. So so that was a plus.
And then going into community service, you said that you got some great exposure from a surgical point of view, and that was obviously a benefit of being at what we would say an outside hospital or a little bit more rural setting. At that point, had you decided that you wanted to follow a surgical path?
So, funny story. When I finished medical school, I said that's enough. I don't want to see another book, another textbook. I didn't think I was going to specialize at all. Although having come up through the years of medical school, I actually always wanted to do either sports medicine or orthopedic surgery or even general surgery, actually. And so, yeah, like I said, at the end of medical school, I was like, I'm done with books. But then I got into community service, and during community service years, I was, based between the general surgery department and the orthopedic department simultaneously. And I had some good mentors there as well. As much as they didn't have on-site consultants, there was outreach from consultants at least once a week, and I learned a lot of tips and tricks from them as well. And yeah, I think then I basically, as I was going through community service years, I had colleagues as well in community service that were, prepping for primaries and things like that. And, I had a second thought, and you said, what, I think I can do this. I wanted to unpack that, or open up that passion again, and relook at my passion for a surgical discipline. And yeah, I definitely really appreciate it in that regard, being in an outside hospital, really, or outside one of the major centers, because I had that hands-on experience. I had that good exposure. Being in community service is also very important to remember. As much as you may not have full supervision all of the time, it's very important to remember what not to pick up. There are sometimes bad habits that sometimes chronic medical officers might have in some centers. I'm not saying all centers, in some centers, specifically in the periphery. And yeah, I made sure that I stayed focused, and yeah, started learning for primaries during my community service year.
Awesome. Now, I'd love to hear your thoughts about orthopedic reg time and the specialty of orthopedic surgery. But before we get there, when we look at the choices facing junior doctors in terms of where to specialize, we always, there's surgical disciplines, there's the physician and internal medicine route, and then there's the non-clinical kind of pathology, maybe radiology would also fall into that route, and then also corporate and legal, something far removed from the clinical setting. A medical degree really is a platform or foundation that can take you into all sorts of careers and places. For you, what was it about surgery in particular that made you say, okay, I think I'm going the surgical way as opposed to those other routes? Was there anything about internal medicine that you said, this doesn't agree with me, or as a person, I can see that this doesn't resonate with me well? Was it just surgery was something you fell into and loved, or was there a very clear decision algorithm that you into your speciality?
Yeah. So yeah, good question. I think the surgical disciplines, the thing I love about orthopedics in particular, is that compared to the non-surgical disciplines, I mean, there's so much variety. I mean, during our week, you have, it's not just the ward rounds and the clinics and the intake. You've got your hands-on in theater as well. And which all surgeons will know is very practical. The surgical skills are something that we all fine tuning on a daily basis. As high up as you go, everybody's fine tuning their skills. And internal medicine, as much as I enjoyed it as well during my medical school years, once I got to community service, and particularly in community service, I used to enjoy watching things like Dr. House. I'm sure you'll know Simon. And I was fascinated by that, and I really loved the way how he used to figure out put together puzzles, if you wish. But in South African setting, especially in a rural setting, it's quite depressing, for me at least. No disrespect to my colleagues in internal medicine, but for me, it just wasn't very rewarding. And there was just, I'm not to say, that's definitely something as South Africans need to work on in terms of, access to healthcare and early access to healthcare, so that we don't get to this point of, this patient is at the end stage of their disease and there's not much we can do for it. And we know that they're most likely going to be palliative. So for me, that was a little bit, wasn't such a draw factor, and hence, chose something surgical.
Right. So, that's obviously affected people's decision-making process. So thank you for your answer. So now I want you to unpack orthopedics. And this is a rotation that as an intern, I haven't yet gone through. So I know very little about orthos outside of knowing that you get orthopedic trauma surgery and you get arthroplasty and you get, tumor and sepsis ward and all of those things. Tell us what orthopedics is really about, because some of us might have some real misconceptions about bones and ligaments and tendons.
Yeah. So if we start right at the beginning, most universities across the country, the exposure to orthopedics is very minimal in the 6 years. Compared to the other disciplines. So orthopedics, as you know, Simon. So at the beginning, you start off. Most people will not be able to get a registrar post. Back when I had started, some of my colleagues at the time were lucky enough to get registrar posts straight out of community service. I, however, wanted to get some experience under my belt. Initially, I didn't want it to be as long as it was, but I mean, experience is never lost, and knowledge is never lost. So I came out of community service. I spent 3.5 years as a medical officer before I was almost 4 years actually, yeah, before I was able to get into a registrar program. And during that time, as I said before, I'd done my primary examinations, which is now definitely a prerequisite and to getting into a registrar program. And as the years went on, obviously I had, got my intermediates. At that time, it wasn't a very not a very common thing for a medical officer to have intermediates before you even get a registrar post. So I had, sat down, I had some fantastic mentors as a medical officer, really some fantastic mentors. And they, opened these pathways for me to, stimulate more learning and progress my career. As much as I was not progressing officially in a training post, I really was progressing as a medical officer. And they could see that and they helped me along the way. To do your intermediate, obviously you require ICU time. And they allowed me to rotate through a facility while I was a medical officer to do ICU time. And then, yeah, I was able to get my intermediate exams as a medical officer. And then I interviewed and cracked the nod. So, yeah, then I started my registrar time. And yeah, so registrar time to become an orthopedic surgeon contains quite a few rotations. So bulk of it is trauma. I mean, we live in a very violent society in South Africa, and the bulk of used to be 4 years, is now 5 years. And the College of Medicine is looking at it being 5 years across the whole country. So the bulk of those 4 years, 5 years is trauma. Then we rotate through. The next following rotations there's your spinal surgery rotation, there's your arthroplasty rotation, which essentially is joint replacements. Then you have a tumor sepsis and reconstruction rotation. Then you have an upper limb rotation. Then you have a lower limb rotation. And then you have pediatric orthopedics as well.
Sounds like each of those 6 months or so at a time.
Correct, yes. So the first bulk of it is 2 years usually of trauma, and you can swing obviously between the two. Like you can drop, you can stop between those 1 year or do 1 year of trauma, then jump into arthroplasty for 6 months, do another year of trauma, then do your senior rotations.
If I'm understanding you correctly, orthopedics is something where you do a little bit of MO time. Do you need outside MO time in another surgical discipline? So would you be well placed to do MO time in gen surg, for example, maybe get some cutting appendixes and things, and then come into an orthopedics role? Or does that need to be MO time within orthopedics itself?
So orthopedics time, you need at least 18 months of trauma of MO time in orthopedics. That is a requirement now for the registrar program. And then they say ICU time, or what was considered general surgery time. So we rotated through the trauma ICU in Nkosi Albert Lutuli Hospital, which sees everything. So and we work side by side with the general surgeons. So you can, to answer your question, you can do general surgery time minimum of 6 months, and then essentially that can be counted towards you being able to do your intermediate examinations. Yes.
And let's say there's somebody who's a registrar in Gen Surg and they're having a look while they're doing their 17th midline lap of the week. They look at that rib cage and they're like, I'm just starting to see a hint of rib. Maybe I actually want to go into bones. Well, I'm just starting to see the brim of the pelvis and those bones look interesting. Do people do Gen Surg time and then come across to orthos? Is there a channel that way, or is it strictly through the orthopedic surgical registrar time?
So to answer your question, we do have sometimes MOs coming through general surgery. In fact, we've got one with us at the moment in our department. Very, very, very strong candidate, obviously, to get a registrar post, and he actually he went all the way up into intermediates, in general surgery, and was like, no, this is not for me. I want to do orthopedics. I've had a passion for orthopedics, and so he dropped a registrar program in general surgery and came across to be an Immo in orthopedics.
Wow. So coming back to the earlier question, because you've clearly delineated the path, and thank you very much for that. I think people have a very clear sense of what's required now to start out in orthopedics. But what is orthopedics really about? What is it that's so gripping about this specialty for you?
So, I mean, I could be stereotypical and say that, it's so cool because we work with drills and hammers in theater, or, we carry dumbbells in our bag and make sure we get in a bicep set during the day, or like we only drink protein shakes tea time. But as much as all of that is true, it's so look, we the bulk of what we do is trauma. Unless you subspecialize and go to a tertiary facility or a quaternary facility, the bulk of what we do is trauma. And most MOs and registrars, that's what they will experience when they go into it. So essentially what it is we have, so let's start off with intake. So like, for example, we've got the MO and the intern will be on call and see whatever comes in. All right. So you'll know that as well, Simon. So they'll see whatever comes in, and then they will book essentially either a patient requires emergency theater, for one of the orthopedic emergencies, or the patient will require, not elective, but essentially booked trauma, which can wait for one of the booked slates. Or we can also see, but which is normally in a clinic setting, we would see elective stuff. So example, osteoarthritis of the hip, for example, or knee that's waiting an arthroplasty procedure. So that's the sort of stuff that we would see in our clinics. Then also, obviously, as you know, we'll have wards where we go through and see all of our patients. Again, we have quite a long waiting list across the whole of South Africa. I mean, we were even on the news nationally with regards to waiting lists, specifically in orthopedics, when they looked at hip and knee replacements. But yeah, I don't want to go on a tangent, but we also have obviously the surgical side of things. So, 2 days out of the week will be, you'll be sitting in an orthopedics theater slate. 2 days out of the week, you'll be sitting in either a trauma clinic or an elective clinic. And then, we've got our ward rounds to see to, and that's basically it.
So what is the best part of that job? It sounds like you spend a fair amount of your time in clinics and in the wards. So maybe a third of your time in clinic, a third in the wards, and a third actually in theatre, which, as you alluded to, is what surgeons actually really want. You want to have your tools and doing the things. What is it that's the best part of your job out of those responsibilities?
I would say, well, look, I enjoy all of it, to be honest. But particularly, I would say I enjoy the clinic to a degree because I get to chat. And I mean, as much as they talk about pushing crowds and things like that, I, usually have a sit down with the patients and we talk, where they are in terms of their goals in terms of treatment, are they understanding with regards to their prognosis, and obviously talking about things like their mental health. Because I mean, you see patients that are coming to the clinic for years at a time, being seen for the same diagnosis. You can't not ask about mental well-being. So I mean, I've had I've joked with myself and saying, if I go into private practice, I won't make too much money because I just talk too much. So obviously in private practice, time is money, eh? So you
a point there, which I think is so important. We don't immediately associate orthopedics with psychiatry or with the mental health of our patients. It used to be like our patient comes in with a problem, we fix it and send them on their way. But as orthopedics revolves around people's ability to mobilize and their ability to do activities of daily living, their independence, and even their sense of identity. If somebody's got a bad leg, people can see that, and it makes people interact with you a certain way, makes people treat you a certain way. So when you speak about things like the long delay, what are some of the causes of those long delays, and what can we do to remedy it? And what's the solution to this long delay for getting treatment?
Sure. There's no quicker answer to that. I mean, there are policymakers at provincial levels and national levels that try to sort this thing out. Essentially, backlogs exist because of unfortunately, the poor turnaround times. Turnaround times, are slow because, we don't have enough access to theatre. I don't want to sit here and say, no, we don't have enough doctors and, but yes, granted, we a lot of the time are understaffed, but I mean, to get to theatre, you need an anaesthetist. And yes, the anaesthetists are understaffed. To get to theatre, you need nursing staff. And the nursing staff are also, pulling a thread sometimes just to, put together a team to make up a theatre. So, and obviously just the sheer bulk of amount of patients that we have to see. And this whole idea of I'd read somewhere about the inverse care law, that 80% of the healthcare workers are where 20% of the population need them, and 20% of the doctors are where 80% of the population need them.
Wow.
You can allude that to private practice or even to rural healthcare. So yeah, that's basically it, and that's why obviously it's a lot more to that. I mean, if there's an aircon issue, we have to cancel slates. If there are, patients who, for whatever reason, might have, not been MPO the night before, then all of a sudden now you just, taking that patient or canceling that patient for that day. So yeah, that's just part and parcel of, what we have to deal with, and part of I don't have a solution to that. Sometimes it might be easier said than done. And let's hope we get the right policymakers in place to make sure the referral patterns are right, we get adequate staffing, and yeah, we can do what we need to do.
I think maybe it was a bit of an unfair question, so thank you for handling it graciously. But I think the answer, as you said, is that like every problem in the South African healthcare, I don't want to say industry, but like everything in South African healthcare, the problems are not easily solved, and our problems are multifactorial, and there's so many things right from the ground up that we need to fix. So I want to bring you back to your happy place. Imagine you are doing your dream list for the week. What are the best surgeries that you do within orthopedics? What's particularly rewarding for you? And when you see something on your slate, you're like, this is what I came here for.
Wow. So there's a difference. There's difference between what you enjoy. Because look, whenever the patient outcome is great, quickly, I enjoy that. And most of the time, that is your everyday bread and butter stuff, which is not something that you would call a consultant in to do. But I particularly am I have a special interest in upper limb surgery. Initially started out with just hand and wrist, but now our facility there's a need now for me to move up to shoulder and elbow as well. So I particularly enjoy I'm known as the upper limb person at our facility. So yeah, at anything upper limb, and I'm there.
So I'm busy reading a book. I'm currently finishing a book called Dr. on Everest by Kenneth Kamler, who's a hand surgeon from New York. Would you ever consider doing like plastic reconstructive surgery as well? That's obviously within parts of the realm of orthopedics. Would you add on a plastic surgery kind of fellowship to what you're doing? Is that one of the things that orthopedic surgeons do?
So yes, it is an option, and in many places in the world, there is overlap with plastic surgeons and orthopedic surgeons, particularly in the upper limb as well. And yes, as much as I wouldn't say I would go, subspecialize in something like that. But certainly wherever there's a need for a particular skill, I'm definitely willing to learn. But I wouldn't say I put myself into a plastics and reconstruction surgeon or to go into that realm. But we do work very much hand in hand with our plastic surgeons. For example, if you have a defect, a soft tissue defect that requires coverage, then we've got our plastics registrars or colleagues on speed dial.
I don't know if that was an intentional pun or not, but I loved what you said about working hand in hand with the plastic. So let's say there's a farm worker out in Ermelo and gets a hand injury and goes to trauma. The trauma surgeons then refer to orthos, and orthos comes on board. At what points do we then have to refer to a higher level of care? You mentioned that there's some stuff that's bread and butter. It seems to me that a structure like a hand with all of the intricate nerves and tendons and things within the hand, and particularly for somebody who's a manual laborer, you don't want to just give that to an Immo in Ermelo. With all due respect to the Immos, I'm sure they're doing great work. How much actually gets referred to a higher level of care? So you're currently working at King Edward VIII. Do you have a massive catchment area that extends out into Natal for all of those farm workers to come to you, or how much can actually be done at a district level?
No, absolutely. Yeah, that's actually a fantastic case scenario and very important for all of us to learn from in terms of what can be done. So obviously the immediate debridement can certainly be done by regional district levels and maybe in some instances. But the intricacies of complex tendon repairs, complex nerve repairs, complex open reductions, internal fixations or external fixations if it's required, can wait after the initial splinting or initial debridement to get to a tertiary center.
Okay.
So ideally, to answer the question, is refer basically after the initial emergency management.
So you don't see many people who've been hit by a car outside your hospital. You see lots of patients who have been treated at district level and then referred on a couple of days later for higher level care.
So no, we actually see a very mixed bag. We currently, the referral pattern, I don't want to say is changing currently in Durban, but we definitely see a mixed bag. We see everything from what should be a district level care all the way up to tertiary level care. So yeah, we see it all really.
Yeah. Dr. Rankin, so you've alluded to some of the pluses of orthopedic surgery and some of the things that are most rewarding to you. But like anything in life, everything good has to be balanced by some of the bad. So what are the cons? What are some of the bad things about orthopedic surgery, especially in comparison to other forms of surgery, subspec, or other ways of practicing medicine? So you might say that orthopedics might have longer hours, or I'll leave it to you to tell us what the bad parts are.
So personally, I wouldn't say, there is a bad part for me. But if I look at the discipline on it, as a whole, I think the bad part comes in as much as, like I said, we have stereotypes, right? And stereotypes that possibly not always a great stereotype, but a stereotype where, that's an orthopod, what do they know? So, and in terms of, for the other departments, recognizing an orthopedic skill set. I mean, we have a skill set. Our colleagues in internal medicine or general surgery have a skill set. We appreciate their skill set, and we would hope that they would return the favor in terms of, appreciating our skill set. I'm pretty sure, if any of them needed a hip replacement, they wouldn't take it on themselves, or a complex nerve repair. So as I wouldn't put it down as, bad for the profession itself, but just something to say that, occasionally you bump into these people who might not say, the funny joke that goes around is, oh no, the only drug they know about is kefazolin because it pumps the good stuff to the bones.
If I summarize what you're saying, there needs to be a little bit more of interspecialty respect. If we
100%. 100%, yeah.
It also grows. So maybe we just put it out there for everyone listening to the podcast. Respect your orthopedic surgeons. They are, as you alluded to, almost 4 years of MO time, plus an additional 4 years of speciality. And the brachial plexus and the arm and the hand way better than others. You have a unique skill set. You might not necessarily dabble in other people's skill set, but that's where medicine's going. Medicine is becoming this isolated, silo-like effect, right? Everyone's subspecing.
Quite true, yeah.
So what is orthopedics going into in the future? Will AI and robots replace orthopedic surgeons? Or if you were to look into a crystal ball, and we've got junior doctors listening to this podcast, and in 10 to 15 years, they might be orthopedic surgeons themselves. What does the landscape look like for them, and what's changing in orthopedic surgery?
So technically, I think 15 years is probably short term, really, because I don't think it should change too much in the next 15 years. But I'll log on to this podcast and maybe eat my words. But look, already we are heading to the way of robots in orthopedic surgery, particularly arthroplasty. So robotic assisted surgery, as well as, everything becoming less invasive, less invasive, spinal surgery, less invasive, scopes that, I mean, you can even do a scope in a clinic setting these days. So yeah, that's the route. To say that, artificially intelligent robots may take the job over, I don't want to say.
So you said 15 years is quite short. Does that mean that 15 years ago, orthopedic surgery was the same as it is today, essentially?
No. So in that regard, I mean, we have come leaps and bounds just in terms of the technology. Obviously, the academics and the science, the literature that's getting pumped out in so many aspects when it comes to orthopedic surgery in particular. So yeah, I mean, our implants have improved. Just an example, hip replacements, bearing surfaces have improved so much. So I mean, that longevity of an implant may double what it did 15 years ago easily. So yeah, so it has changed, but I mean, I suppose, I would still consider myself young to say that I don't know how far it can change in the next 15 years.
Cool. So I want to let you be the creator of your ideal orthopedic surgeon. You mentioned that you have some candidates who've come in that are ideal candidates, or that they've got great attributes that are going to make them good surgeons. So if you were to design your ideal orthopedic surgeon right from the head to toe, so the way that they act and the way that their personality is, what are some of your key ingredients that make somebody a good orthopedic surgeon?
So I'm going to have to exclude the head to toe part that you said, because there's no physical attribute that I would put down to say that somebody is an ideal orthopedic surgeon. And many people will think, no, you need to be strong, and so any way, shape, or form type of person can join orthopedics. And I've told many of junior registrar, when they're coming in on their first day, I said that, we will turn you into an orthopedic surgeon. It's just a formality. You're here for 5 years, and it's just going to be a formality. As long as you want it and work hard, it's going to just be a formality. Whoever comes in the door, no matter what they look like, sound like, what they know, we will make it just a formality. That if they want it, we will want it as well. So obviously, characteristics, hardworking, reliability, making sure that you do the basics well, even when you're not being watched. That's a critical point. And yeah, I would say just hardworking and reliable, and making sure that that you remember that you owe your patient, every patient, the respect and the type of care that you would want your mother, brother, sister, father to attend or to be attended by. So yeah, a lot of it comes down to heart, and a mentality and a work ethic, and yeah, that's it.
It comes across that you are very passionate about being a good supervisor and a good senior. And what I love about what you said there is that it's okay to come in not knowing everything. You came into your registrar post to be made into something. So you don't arrive complete. You don't arrive and say, I'm here, I'm going to be your dream registrar. You have to become, that's what reg time really is. As we read this segment, our upcoming segment is going to be about what it's like to be an intern curator and managing these young doctors that are fresh out of medical school. In your final thoughts about orthopedics, are there any lessons that you've learned through your time in orthopedics, reg time, and as a consultant in orthopedics, some of the pitfalls and perils that you've encountered that you can now pass on a lesson to junior doctors?
So look, orthopedics as a whole is very vast, and it's important for junior doctors, coming into orthopedics, to obviously know the basics. You're always going to start out, even in community service. I'll go back as far as community service, and for argument's sake, even as a student, when I tell all the students, this as well, just as much as you only get such a little bit of exposure in medical school, read. You don't have to know everything about it, but you need to be able to know that when I'm looking at that wrist x-ray, that is cane box disease. So if that is cane box, if I don't know cane box disease exists, I won't know that somebody else can do something for it. So essentially, just familiarize yourself with as much as you can, be practical, be in the clinics, see patients, take your time with patients, listen to your patients.
Very, very good. So final thoughts about orthopedics. So if there are any resources that you know of, any texts that, I mean, you said read. If somebody really wants to start preparing themselves for orthopedics, even as a medical student, you said the exposure is not great. At WITS, we did 2 weeks of orthos. It was very limited exposure. It was great teaching, and being at an academic hospital in Johannesburg, saw tons of trauma. We saw tons of arthroplasties, even we got into theater. But if somebody wanted to read ahead and resource themselves in this area, are there any podcasts you can suggest? Are there any YouTube channels you can follow? Any books and magazines or journals you can subscribe to?
I will refer you to, well, in all medical offices and registrars and orthopedics is orthobullets.com. And so that is probably the easiest read resource. In terms of podcasts, there are many. I probably listen to some subspecialty podcasts, so I don't really follow a general podcast. There obviously are journals and things and journal club podcasts that I listen to as well. But in terms of a resource, orthobullets.com is certainly a nice, easy read, easy searchable in terms of, even, medical officers on call. Go and quickly, research, okay, this classification, these are the investigations, this is the management. So yeah, that's what I would refer to.
So I want to summarize this first segment that we've had. First of all, thank you so much for unpacking orthopedics a little bit to us. You did tell us about some of the challenges within our system, but overall, orthopedics is rewarding because patients come to you with problems that you can do something about. For you, most of the rewarding parts are where patients get treated quickly. They get a change in their ability quickly and obviously as pain-free and complication-free as possible. And then you spoke about some of the challenges about getting a registrar post. There's many people who do Immo time for a good number of years before those posts open up. We spoke about the 4 and now 5 years within orthopedic surgery and how those rotations work. We also spoke about orthopedics going into the future. That's, as much as people say AI is coming and the robots are coming, it still remains a field that has massive potential for growth, massive career opportunities, and you see a wide spectrum of things. And in South Africa, that's obviously mostly trauma, but there are other things as well. We spoke also about orthopedics resources and what makes somebody a good orthopedics student or registrar, which, as you alluded to, just makes you a good student in general, right? So a good doctor in general.
Yeah.
One final question that I have about orthopedics: if you could create a medical device that would make orthopedics better for you as a surgeon, what is lacking in the specialty? What is an aspect of your task that sometimes gets frustrating or you feel limited in?
I would say, well, again, it's very far-fetched and futuristic, but X-ray goggles or X-ray glasses. Because a lot of the time you rely on closed manipulations in a clinic setting, or you require a quick answer in terms of adequate reductions, or, again, if you're in an operating room, you haven't yet, brought out the fluoroscopy, is the screw too long? Is it too short? And you only got this big machine now to see, and get only 2 views maybe sometimes. But yeah, I would say X-ray glasses.
We're back with Dr. Mario Rankin for the next segment in our podcast, and we're still talking about orthopedics. And we touched on the road to specializing in orthos, including Immo time and doing your primaries and doing your intermediates. Now let's talk about the final stretch. As you come into land towards the end of reg time, when should people start thinking about writing their final exams, and what's the exit like from reg time in orthopedics?
Thanks, Simon. Yeah, so when you should be starting to think about writing your finals is usually at around 4 years, well, 3 to 4 years in. Initially, it used to be you were not allowed to write before 36 months. Now being a 5-year program, they prefer that everybody writes after their 4th year. But remember, all along the way as well, there's a Masters of Medicine, or M.Med, as you will, for every registrar. So to get out a paper, essentially, So yeah, the finals, heading towards finals, you essentially got to see yourself as becoming that now finals candidate. I mean, a lot of the time there's this imposter syndrome in many specialities, realizing that, that's going to one day be me. Can I do it? Am I good enough? So, a word of, advice really is for registrars across the board. Prepare yourself mentally from making that transition from being a junior registrar. See yourself as that senior registrar. I mean, you watch senior registrars going for exams, answering questions well, so put yourself out there, around about, even, I mean, as early as the first, second year, put yourself out there, put your hand up when seminars are on, ask questions, give answers when you're answering, when you're asked questions in meetings, or even when you're not asked questions. So get yourself ready, ask questions, talk in meetings, and see yourself as that finals candidate sooner rather than later, so that you're mentally prepared to start talking and walking like a consultant.
Wow. Yeah, I mean, that's a difficult thing, right? You need to start meaning as you intend to go and start acting like you're going to be a consultant in a very, very short amount of time. What are some of the considerations that go into choosing an M.Med? I mean, you obviously need to go through a proposal process, and that's going to refine it and shape it. But when you're approaching M.Med, I know there's this emphasis from the colleges of medicine to make sure that every candidate graduating has an M.Med of some sort. And sometimes, because it's something that has to be done and people not necessarily interested in being a research scientist in medicine, sometimes the M.Med is not of the highest quality it could be. And I say that not as somebody with an M.Med, but just from what I've heard. So how should the M.Med be approached, and what really is the goal that you're trying to generate in your future surgeons?
So yeah, you've got a very, very good point there, Simon. And there have been, even PhD candidates or who have published on the fact that, are we really just diluting the quality of science out there? Because a lot of the time people are just pumping out papers because they need to be pumped out. Are they really adding to the body of knowledge? Are they really adding science to it? I mean, you may have heard of, I mean, many a time there are sometimes, I won't say ridiculous because everybody's M.Med is special to them, but sometimes it's just a topic that's just to get an M.Med done. And a lot of the time, to be honest, when you're in the moment, that's really just what you want, hey? You don't want to change the world. You just want to get a Master's of Medicine done, because, prior to, gosh, I think it was 2014, all the specialists before that don't have Masters of Medicine. They don't have M.Meds. So not so much, I'm not saying that it's not necessary, because absolutely you learn as you go how to critique scientific papers. You learn your journal articles. You learn how to critique. You learn how to analyze evidence. So in terms of what you need, you obviously have to have an interest. And there's the saying that goes around is, nobody is going to be interested in your topic other than you. So you've got to be passionate about it. You can't expect your supervisor to be knocking on your door every week to ask, how far are you? You got to be passionate about it, and you've got to, make progress along the way. And don't just leave it for the last moment when, you've done with finals now and you've like, oh gosh, I still have to put out a protocol, which has happened before. So, make steady progress along the way. And, there's a lot of structures in place at the moment for registrars to make sure that they progress adequately.
So I want to take you back to your experience from when you finished your final exams as an orthopedic registrar and now became a consultant in orthopedics. Because unlike graduating from medical school, when you graduate from medical school, you know that the future holds internship and community service, which for many and not all is guaranteed employment for 3 years, basically. And then after that, you might experience a period of unemployment, but many people will find employment after community service. And then this mountain is still ahead of you of specializing. What was it like finishing your final exam, knowing that you're done? I mean, did you feel anticlimactic? What was the sense like after putting in so much effort to reach that goal? Were you left with like, now what? Or were there already things lined up for you?
Look, I wouldn't say it was anticlimactic, because I mean, you've been working at this for years and years and years, And in the essence of it, though, and many consultants and professors will tell you as well, now the real work starts, because only once you're done, only then do you know what you do not know. And only
Oh,
then
wow.
do you figure out what you do not know. Because as much as a consultant who is writing finals at the time is probably the most well-read individual in the room, broadly read individual in the room, you still have to now move on to, work life and, put everything into practice. For me as well, like I said, it was just a relief. I had obviously sacrificed so much, especially family time. I mean, my son was only 2 at the time. My first son was only 2 at the time, and having to go through like second half of reg time with, my son was born in my first or second year of reg time, I think it was. And so I mean, I had to sacrifice so much, just from still having to be present as a dad, and getting up at night and doing the bath times, and doing everything, so and I was just happy that now I could give my whole self to my family.
Wow. Great answer. So one final question about orthos then. Is the option to go into private or stay in public, or what's the road? Once you specialize in orthopedic surgery, what's it like?
Yeah. So you can definitely, as soon as you get your HPCSA accreditation or registration as a specialist, you are more than welcome to go off into private practice. And as much as there are no or official academic subspecialties in orthopedic, many people in orthopedics in South Africa, at least, many do decide to subspecialize and do a fellowship in a particular area of interest. So that basically just means doing 12 months under an expert at a particular facility, and then now you are argument's sake, foot and ankle subspecialist, or a shoulder surgeon, or an arthroplasty surgeon. So many do that. But at the same time, I don't want to punt private practice, because we do need specialists to stay in the government sector. But yes, setting up a private practice obviously has its own challenges. And the stress of private practice. I mean, I've heard from many a colleague in private who had said they would in a heartbeat, drop private practice for a head of department post, because the stress remuneration ratio just doesn't compare. The amount of stress in private practice. Obviously, the money is good in private practice. Not to say that it's bad in state practice, but obviously just a lot better in private practice. But at the expense of what? At the expense of your well-being, your family time.
So what you're saying is, as stressful as medical students and interns and junior doctors can be, they're not as stressful as private practice.
I don't want to say like that I've walked that walk, but from the outset, from what we see, yes, quite right. Many of our colleagues in private would tell us that.
That was meant as a segue into our next segment in our conversation, which is to unpack your role as an intern curator at your site and at your hospital complex. So for those of us who are interns, we see this person who's the intern curator, who's the person who's going to sign off our logbooks and our go-to person if we have any issues or if we encounter any discouraging things within our internship. But for you, what is the role of an intern curator really? Is this something that you were given willingly, or is this something that you were shoehorned into?
So just to talk about the role itself, as guided by the HPCSA, is that the intern curator essentially is an assistant to the medical manager and the CEO of the facility, to be an intermediary between management and obviously the workforce on the ground, which is the interns. And to tell you how I got into it, so essentially the previous intern curator a couple of years back was leaving our facility, and she was obviously, like I said, offered a post somewhere else. And then when she had asked the intern committee at the time, or the interns at large at the time, for any suggestions of who would be a good, follow-up intern curator. My name happened to, pop up on that list. As much as it's very much, it's heartwarming to know that, I had an impact in terms of being a mentor, being shared a bond with interns, and just believing in them. There's somebody that can relate to interns and the life of interns. I mean, I'm not somebody that said, "Oh, I had it hard when I was younger. Everybody's got to push through." We all got to remember that we've got to look at making sure that the future workforce, or the future of medicine in general, not just orthopedics in general, is looked after, because we've got to relate to the stresses of junior doctors. We've got to relate to what is happening in this day and age. Yes, it might have been different 10 years ago, but we've got to be able to relate to the now. And I was very happy to say that I would take on that role. And well, first of all, very privileged to have been nominated into that role. And yeah, as much as I'm not, it's not part of my official job description, I don't get remunerated for it at all. And occasionally has its stresses at certain times of the year. But yeah, it's a role that I carry with pride. Yeah.
That's a great answer. And I think it's also important to remind everyone, like you said, it's a role without remuneration. It can sometimes be a thankless job, and a job that comes with stresses that aren't of your own creating. If you have to sort out an issue with an intern, either, for example, if there's an intern who's not submitting sick leave forms adequately, that's something that you go out of your way to help resolve. And it's an extra stress on a family man and on a surgeon who's head of a busy department. So we need to thank our intern curators, So if I was to ask you, what makes a good intern? Not just an intern at your site. I think you've alluded to many of the attributes of professionalism and having a heart for what you're doing. But what are some of the things that interns can do to help to improve from your experience, these interns are doing on the ground?
Yeah. So it's hard to describe, because I mean, at the end of the day, we've got so many different personalities, and all of them. I mean, I've been privileged enough to know some really fantastic interns, fantastic future leaders, of healthcare and well, at large, the world at large. In terms of what makes a good intern, again, comes down to, and I say this at intern orientation as well. Your character is going to be building your reputation. Your character essentially is your currency. And if you develop that, a good character, or a poor character for that matter, it's going to carry you and turn into a reputation. So essentially, being enthusiastic. We don't want you to know, or an intern to know everything on the first day of a rotation. We don't need them to know everything on the first day of a rotation. We just need an intern to be enthusiastic. We need an intern to be reliable. And, it goes this, again, without saying, is, professionalism it's not really easily taught, but you've got to, be and set an example as a senior. We as seniors need to set examples to make sure that, hey, our consultant is, on time. I can be on time as well. Or my consultant is staying, at work until a certain hour of the day. I also need to stay at work until a certain hour of the day. So it's about, again, making sure that you are that professional, as we spoke about too a bit earlier. You are that professional that you would hope that, your mother, father, brother, or sister wants to be attended by. And obviously, if there's a lack of professionalism, or there's a lack of reliability, certain individuals may build up a reputation for that. So yeah, that's how I would put it into a box.
So I've heard a definition of reliability that I want to share, and then maybe we can build on that, because one thing that comes through is reliability. You can't lean on somebody who's unreliable. There's a proverb that says leaning on somebody who's unreliable is like walking with a broken leg. Thought that might interest you as an orthopedic surgeon. So reliability is faithfulness with accuracy. So being faithful to carry out your instruction or your request as a senior, and then to do so accurately, because it's possible to be faithful and do what you think you've been told, but do it inaccurately. And it's also possible to be accurate but not be completely faithful. So maybe you can build on that reputation. What for you is reliability? And you're welcome to just take that definition and move on. But what other aspects do you think are important for the reliability of a junior, especially because there is a hierarchy in medicine for a reason, right? We're all learning and we all have a referral chain and a chain of command. So what makes us reliable interns?
Honesty at the end of the day, because I might think, and you quite rightly said, being accurate about something. If you know that you cannot accurately, faithfully output a certain outcome that a senior is requesting, you need to be honest and upfront and say, rather than not do it and rather than do it inaccurately, just be honest and say, hey doc, I need help with this, or hey doc, I think this amount of workload is a bit much. Do you mind if I get a colleague to join me or to do certain procedures with me? Being honest about your abilities, and being honest also about, certain things that might not be going on at work. I mean, there's only so many times you can call in late in a month to say that you had 5 punctured tires in a month. Is a bit unlucky. So, I mean, again, honesty in that regard and communication, so communication also is key. So respecting yourself enough to be honest about whatever is going on, whether you're late, whether you're not going to come into work, whether you can't do a certain procedure on your own or not, and respecting your colleagues around you.
Fantastic. Dr. Rankin, you mentioned that you can see some of your interns showing promise and potentially being world leaders in certain areas. Is that something that you are then able to foster in your role, or is that really an independent thing for the intern to pursue? I mean, do you see some diamonds in the rough and you're just like, wow, I really wish I could give you more, but I can't?
So my goal, to add to what you said, my goal really is to increase the number of diamonds in the rough, to set such an example, to say that, we're not asking everybody to be an award-winning international doctor, medical doctor, but for them to be able to believe in themselves, to be able to get there. And I've alluded to it in some of my social media posts as well. And having belief in your juniors is very important. An encouraging word goes a long way. I mean, I can look back as when I was a junior. If I had a senior who would, just very rarely does it come that you get a senior that say, well done, even for simple things, getting an answer right in the X-ray meeting, or getting through the workload for the day. A word of encouragement really goes a long way, and it doesn't take much. It doesn't take much from a senior colleague. And when I say senior colleague, again, a medical officer saying it to a junior colleague, or even a consultant saying it to a medical officer or an intern. And we need to be proud of them. There are certain individuals, and a lot of individuals, interns, that work very hard, and we need to be proud of them, and be proud of them now. Be proud of them. Wait for them to be award-winning physicians or surgeons internationally, and say, that was my intern, or that was my medical officer or registrar. This is my intern. This is my student. This is my registrar, and I'm proud of them now. Don't wait for them to be proud of them. And at the end of the day, I think also part of the role is just kindness. And it's one thing that I would hope that the previous batch of people who nominated me into the role is just be kind. It doesn't take much to just be kind. And there's also a saying and also I had a post some time ago about the only difference between a consultant and a registrar is the head start on experience and the head start of knowledge that we got on our junior colleagues. Other than that, we all started from the same place. So just be kind.
Yeah, great answer. And imposter syndrome is real. So the words of encouragement from our seniors go a long way. When we're dealing with the stress of work, to just remind ourselves, like, this person believes in me. This person said I'm a good doctor, and they are far more experienced than I am, and their words have gravitas. So thank you for that. And then maybe you can share what it's like going through the intern changeover. So when interns are completed, they're currently 2 years, when they completed their 2 years and then you get another fresh batch of interns. What does that mean for you as an intern curator? And then also, what does it mean for your hospital? I imagine that being a patient on the 2nd of January in the new year is possibly not the best time to be a patient, or is it? Because people are more careful to catch mistakes, they're more careful to ask questions.
Yeah. So that time of year, around December, January, well, getting towards maybe even November, it's obviously we get our list of new interns for the year, and then it's my job to make sure that allocations are done across all the first year rotations, and that's probably one of the biggest headaches. I know by the 31st of December, I was already on version 12 of the allocations. Wow. Because of the amount of swaps, so either this person is not coming in on the rotation, or this person can't make it, the student has to repeat a block or whatever, and certain interns had made their own swaps, etc. So I don't mind it, because you have to be lenient to a degree in that regard. So that is a stressful time of year for the duty of intern curator, and then being on call in a first year rotation has its, I suppose, perks and pitfalls. Being a patient on that New Year's weekend in general surgery, obviously you may see a few startled, fresh doctors. But the good thing is we've had at least our facility, we've had very good transition from first year into second years, whereby some of the first years stayed on, and they basically dualed those calls. So essentially a first year was linked with a second year, or a new intern with an outgoing first year into second year. So they were not left in the lurch in that regard. And look, and I tell them this at orientation as well. It's tough work, it's many of them coming into their first job after so many years, and the working world is different, and a lot of them might even regret their career choice in that first week of calls. But that's normal. That's absolutely normal. A lot of us went through it. It's taxing, being on your feet sometimes for 26 hours straight. Emotionally, everybody handles things differently. But it's important as a senior to let them know that it's okay to not be okay. It's okay to struggle.
Dr. Rankin, if I can ask you, it seems like you've set up intentionally a good handover to make sure that there's a smooth transition from first year to second year. I know in my hospital, we didn't have that, where the second year was partnered with the first year. What about at higher levels? Do you make sure that your MOs and regs are not people coming in brand new as well? So do you make sure that you've got a senior on call who is well familiar with the environment and knows that there's going to be new interns, so that they kind of brace themselves for this change?
Yeah, so at a more senior level, medical officers and registrars, again, as you said, we try to make sure that they are, doubled up, a junior registrar with a senior registrar, a junior medical officer with a senior registrar. And particularly, again, like in our facility, we don't usually have that problem. We've got a good bunch of medical officers, well experienced medical officers. So it's not as much of a problem, slightly higher up.
Okay. I want to now ask you a question about the experience from a mental and burnout point of view and handling the stress, because I can say that my experience so far, I have found second year internship far easier for a number of reasons. Number one is that the workload is less. Number two is that I'm familiar with the environment and how the hospital works. So there's just that efficiency, you do things better. But also my coping mechanisms are in place. Whereas in the beginning, I didn't necessarily know, like you say, you don't know what you don't know. Do you find that as you progress out of internship into more senior levels within medicine, do you find that the stress is less? Do you find that burnout is less, or is the stress different? What's it like from a mental health point of view as you move up through medicine?
So starting down at, obviously, we know, and we heard Dr. Alicia Porter allude to it as well in one of your previous episodes, that medical students are probably the most at risk, so we need to recognize, mental health of medical students being a concern. And then obviously now getting into the working world, our first year, as you alluded to as well, first year rotations are tough. I mean, to come straight from university and be thrown into a very busy labor ward on the first day of work, or be thrown into a very busy casualty, whether you're in, dealing with the gang violence of certain areas. We live in a very violent society, so those have their own stresses. And again, everybody develops, has their own coping mechanisms, and another thing I've pointed to at orientation, a lot of individuals may think up front, no, I'm strong, that won't affect me, I don't mental health, or my mental wellness is okay. So, and what we started out, or not we, I must say, I've had some very excellent first year interns, well, from last year, they're now second year interns, devise a mental wellness program. And this is really a fantastic thing that I really hope grows across the province and hopefully even the country. And it's still obviously in its early stages, but they've obviously presented it to me, and it really looks fantastic. So not so much looking at mental health, but promoting mental wellness, and just checking in with each other from time to time, and certain coping mechanisms that they can try. Again, like I said to you, it's about having an open mind about it, because as on the first day of work, even before you've started your first call as a first year intern, you think, I'm fine, I'm going to be okay, this is okay. But I mean, as the weeks and months go on, it's quite taxing. So promoting a mental, and I'm very excited for our, and as I said, we've got some fantastic interns, and they are promoting this program, and I'm really excited to see where it goes. I really hope it goes far.
That's great. I'm so excited that the interns themselves took it on board to see an opportunity to be a service and a resource and a help to one another, because sometimes we're so caught up in ourselves, we don't even look next to us to offer a word of encouragement and to be a resource. Then internship, I mean, we know what the goal of internship is, right? It's to provide exposure, it's to provide an opportunity to now apply all your knowledge and to learn things on the job that you just simply can't do as a medical student. So what can we do to improve the internship program? Are there still gaps? And I recognize that this is now asking a question of somebody at the hospital, not at kind of HPCSA, and
yeah,
I'm not asking you to, I would just ask you to put a hat on as somebody who's experienced intern life from a different side. And what can we do to improve internship in South Africa?
I think we should consider the job or the training post as an intern being just that, being a training post, and not so much a clerical post, talking about, interns just filling out documentations and, running from place to place, being messengers or porters, or, if we could shift the ratio of administrative work to pure training work, which currently I'm sure many interns will know, a big part of their job is administrative, filling out forms, and, yes, granted, a lot of it is clinical and getting their hands on as well. But I wish we could change that amount of exposure and increasing the training amount and decreasing the administrative part side of things.
That's a great answer, and I wholeheartedly agree. I come from a hospital where unless you are actively chasing procedures and you're saying, I want to be in theatre, I want to do this, please can I have the opportunity to do this chest drain? It's very possible for you to hide as an intern in the academic center, because there's lots of MOs and registrars who will do the task, they'll do it faster than you, they'll do it better than you, and they want to get the work done, So if you're not proactive and saying, please can I get this opportunity with some supervision, it won't be offered to you. Dr. Rankin, we're coming towards the end of our episode. I want to again thank you so much for your time. I think your answers have been fantastic. They've opened up my understanding of orthopedics as well as internship to a whole new level. If I was to give you the platform now to speak about something else, if there's anything that you believe you want to pass on to junior doctors and medical students in South Africa, this is your platform now to share what's on your heart.
I would say, again, it might sound very cliche, but just believe in yourself, have goals, know where you want to go. Internship obviously is a tough 2 years. Community service can be just as tough as well. And just, remember to check in with yourself from time to time. Don't let the burdens of work life, and whether it be, the amount of work or even interpersonal relationships with colleagues, don't let that get you down. I mean, we see that as well, even from junior doctors, interpersonal relationships. That may not be obviously the greatest, but again, that's part and parcel of the job. But stay focused. Remember your professionalism. Give your best in everything that you do, and treat every patient with a fresh mind, fresh, bit of respect. And yeah, you'll definitely be an example for your future generation as well.
Thank you very much, Dr. Mario Rankin, for everything that you've contributed to this episode. Thank you for taking your time out, joining this video call from the call room at your hospital and being on call and being available to your registrars. Thank you so much for who you are as a doctor. You came highly recommended from your juniors who've passed through under your supervision and your encouragement and your training. So again, just from our audience and from myself, thank you very much.
Thank you, Simon. Really, really and thoroughly enjoyed that as well.
Well, that's it for this week's episode of the Dr. Coffee Podcast. Once again, thank you to our special guest, Dr. Mario Rankin. I hope you enjoyed it and feel motivated, encouraged, and inspired. If you have feedback on what you thought of this episode or anything else on your mind, please get in touch. The podcast's email address is drcoffeeza@gmail.com. That's drcoffeeza with no punctuation marks. We're also on Instagram, Facebook, TikTok, and YouTube, and you can find links to these in the show notes for this episode. Consider sharing this episode with fellow junior doctors and medical students in your world who you think would benefit from the content and enjoy it. Thank you so much for your support.